Thank you for inviting us today. I really appreciate everybody's support over here, and thank you for coming and joining us today. We're going to be talking about the con law, my imaging center, and what we are trying to do over here. I'm going to try to keep it as simple as possible, and I'm going to leave the technical questions for Josh to answer later on. But you're happy to ask any questions at the end of the discussion. So my name is Gajendra Singh. Like I was mentioned, I was a general surgeon in India. I was trained here in general surgery and liver transplant. I do in my practice all general surgery, GI cancer surgery, including liver and pancreatic cancer, and whatever comes to the door, whatever I can help the people with. My big portion of practice has been doing cancer surgery, including like liver, pancreatic, colon, stomach. And those patients do need a lot of imaging done before the surgery, at the time of the surgery, and after the surgery. And for many years, I've been hearing how much it costs for them to have the imaging studies done. Sometimes they would come and just sit in my office and literally cry. Like I went to the emergency room 2 weeks back, and I just got a $10,000 bill, and I make $2,000 a month, and I don't know where I'm going to bring the money from. And some of these bills are for the imaging. Most of the bills, if you see, going to the ER visit, doctor's office, or specialty care, they come for the imaging. Some of the patients have sent me the bills for imaging, which have been like $20,000+ for simple imaging. So that gave me idea to do something about these things so I could help out the people in the community. And I had a personal experience in 2017 where I needed an ultrasound on myself. And there's an imaging center down the street from my office, and I just walked in a T-shirt and simple clothes, and I said, they know me by name, but they don't know me by face. So I said, this is my prescription, I need an ultrasound. And I was quoted close to $1,000 for a simple ultrasound. And then I asked, like, is there gonna be any other reading fee on it? And she was a little hesitant to answer that question. She said, maybe. And I said, how much is it? Not sure, like it's $200, $300, yeah, something in that range. So they won't tell you these things up front, that there is an imaging fee and you're gonna get another bill, because the radiologists are most of the time not part of the hospital system, and they will bill you separately. Their job is to collect the money up front. So I'm looking at a simple ultrasound for about $1,200, $1,300, and I just took my prescription, I said thank you, and I just walked out of there. While I was walking out of there in June 2017, I made a decision that I'm opening an imaging center. $1,200 for a simple ultrasound was too much. And in August 2017, I opened my imaging center, starting with ultrasound, and then after the echocardiogram, CT scan, X-ray. And for the MRI, I realized that I could not get an MRI. As I came down to Raleigh, I talked to the folks in the state office about getting an MRI, and they said you can't have it because there is no projected need for MRI in Forsyth County. I said, what can be done to that to get an MRI? I said, you have to apply to get a certificate of need. That's going to take 2 or 3 years to decide. And administrators sitting here in Raleigh office have to create a need. There is a need. The patient needs the MRI. So there is a need out there, but those administrators have to project the need over there. Then it goes through the process, takes several $100,000 an application, an attorney fee, and this several years of process. And even after that, it's not a guarantee that I will get an MRI. That will project a need, and anybody in the country can apply for that certificate of need. Like somebody sitting in California decides to come here and start an MRI center, they can do that. And I said, that doesn't make any sense. People need MRI. I want to provide an MRI, but the state won't allow it. And even if I tried to ask the state to create a certificate of need, it does not guarantee that would come to me. So the other option for that is to get a mobile MRI, which is very expensive. So we try to provide the MRI services with a mobile MRI, which we have done in past until lately. But now we joined the hand with Institute for Justice, and we explained to them what was going on and what we were trying to do. And they understood and what we were trying to do. And ultimately, we have filed a lawsuit against the state of North Carolina to repeal the certificate of need law to get my own MRI. since we have started doing our own MRI and our own imaging center, it is interesting to see that there's a local hospital and imaging center. They have started to reduce their prices, and which we found out firsthand when a patient says, like, before I had my own imaging center, and we will send all my patients to different places, like, hey, you can go get wherever you can get it done cheap. And they said it's going to cost you $2,000. And we asked them, ask them now, like, how much they said, tell you now. Well, they have cut it down to $1,000. So what certificate of need implies or tried to do in past is to keep the healthcare cost down. And what we have tried to do is we have tried to open an imaging center without a certificate of need with MRI, and it has impacted the market where it has started to bring the prices down, which is the whole purpose of us saying that certificate of need doesn't help the community. It keeps the prices high by non-competing, by restricting the new people and coming into the market. And we have shown that if we have more access to these facilities, the imaging modalities, we can actually bring the prices down very effectively. The one sad part of this is that a lot of time when in my office, my surgical practice and imaging center is in the same building but in a different portion, my CT tech or ultrasound tech will call me like, can you just come in here for a minute? And I walk in there, and these patients have like abdominal pain or chest pain or leg pain, and they've been sitting on it for a long time. For them to pay for an MRI or CT scan versus feeding their kids, I would do the same thing. If I couldn't afford it, I would put it off as long as possible. When we scan this patient, we see that they got cancer, and it's already spread everywhere. And so my tech, when they just call me, see, and it's like, can you look at this thing? Is it really true what we're looking at? And I said, yeah. It's just cancer spread everywhere. We can avoid all those things if we can provide the affordable care and make it accessible to the poor people. Nobody should be dying from not having access to the medical imaging or professionals or specialists. We live in the richest country in the world. We have all the possible technology in the world in this country, but it is not fair for the community if half of them or 20% of them can't afford it or can't have it done, and they're gonna die. If a 35-year-old walks in here that I have a pain in my belly for the last 6 months, but I work as a construction, I don't have insurance, but now I can afford it, I can pay you $400 or $500 to get this done, and you see it cancer, and how do you tell him that if you had the CT scan or MRI done 6 months or a year ago, you would not have died? I think this is shameful on our medical profession as a society that we can let these people die. That's a different aspect, but for us, it gives me gratification when people walk in there, it's like, I've been waiting for this thing, thank you very much, here's your $200 for ultrasound. So we do ultrasound for $200, which I was asked $1,200. Anywhere else you go, there's a fee for imaging and reading. We have combined everything, consolidated, made it simple. There is no bill after they leave. When they pay it, they're done. There are no mystery bills. Like, in my family members have gone to the doctor's office and emergency room. You have the bills keep coming, and I've been doing this coding and billing for many years. A lot of time, I can't understand those bills. My wife had surgery done. When I saw the bills for simple surgery was $37,000. Some of the things I could not understand. Even I know what was used in the surgery, I still could not figure out what was those bills for. So I think we have to simplify all these things. For us to file a lawsuit is just to provide the services to the community who needs it. Even if we have insurance, it is very expensive. I have a Blue Cross Blue Shield. My deductible is $6,000. I pay over $20,000 a year, but we barely use $3,000 or $4,000. Not everybody can afford it, this kind of insurance, and paying this kind of deductible and out of pocket. We are trying to provide the services to the community which they can afford, and it can be done. We don't have to have these services higher. The price is so high. There may be one region or another region for the hospitals to keep these prices high, but if we can open the market, make it a free market, and open for competition, I think we can do it. We have to just all work together. There's some legal questions, and I'm going to pass this on for a few minutes for Josh. And if there's any questions, I'll come back, and I'll be happy to answer more questions. Thank you.
So it's exciting for me to be here. I was a big fan of John Locke in undergrad and at law school at Carolina, and I had a number of speakers from here come speak to my Federalist Society chapter, so it's great to be here and to see all of you here and to have a lively discussion. I want to start by saying that my interest in this case is actually very personal. In 2004, I mean, I don't want to embarrass some of you, but in 2004, I was 11 years old. And so I fractured my lower back. L4 and L5 in my vertebrae were completely cracked all the way through. I was just a kid, and I walked into the doctor's office, and my doctor told me that, or told my mom rather, your son's never going to be active again. He's never going to play sports again. He's basically just going to be in chronic pain throughout his life. And that ended up not being true. Medicine is a miracle. I had a wonderful surgery a number of years later that fixed these issues. But throughout, I had a ton of MRIs. I had a lot of scans. And my memories as a kid of my mom are substantially of her sitting on the phone trying to figure out not only how much she would have to pay out of pocket for these scans, to no avail, and trying to figure out with my dad how they were going to afford it. And so when Dr. Singh contacted the Institute for Justice about his situation, I immediately thought back to my childhood and how big an impact my parents' struggles had in our family, and how this issue is important for people across the state and across the country. So what I want to do today is explain, this is a really complicated law, but I want to explain why this lawsuit is actually very simple. So the first thing this law does, or what this law really does at its core, is it establishes healthcare monopolies. That's what the law does. Now, we can debate about whether that's a good thing or a bad thing, but the law establishes healthcare monopolies. It operates by banning Dr. Singh from acquiring an MRI scanner unless he first obtains what's called a certificate of need. A certificate of need is a government permission slip to provide certain healthcare services. Only providers who already have a con can provide services. Everybody else is excluded from the market. To get a con, state planners in Raleigh have to first project a need for whatever service is regulated in what's called a planning area for the upcoming year. Assuming econ folks are shuddering at the idea of state planners projecting a need in the market for the forthcoming year in what's called a planning area, but that's how it works. The state calculates projected need based on things like the number of scanners already in operation and the number of scans those scanners performed. And because the planners didn't project a need for a new scanner in 2018, Dr. Singh's categorically banned from purchasing a scanner. Now, even if they did project a need, Dr. Singh would effectively still have no chance at getting a con. NC's con application process is incredibly onerous and expensive. Feel free to ask me questions about the process in the Q&A, but the short version is that submitting a competitive application based on consultants that we've talked to and seeing it through to completion would cost Dr. Singh about $500,000, while established MRI providers would be given opportunities to thwart, undermine, and challenge his application at every turn. The last time there was a need projected that actually was signed by the governor in Forsyth County for an MRI scanner was 2010. That con wasn't awarded until after substantial litigation in late 2013. So you can see how somebody who wants a scanner today has to think about, do I have the money and the grit to withstand this process 3, 4, 5 years down the line? It's a tough road ahead. So the result, the practical effect on providers like Dr. Singh is that he can't purchase an MRI to provide scans that, as he's shown you, his patients actually need, people who he's talked to actually need, because the hospital down the street already has one. And that's literally true. There's a hospital or a provider down the street from Dr. Singh that already has multiple MRI scanners, and the reason he can't have a scanner is because they already do. Fortunately, in North Carolina, that's not constitutional. North Carolina Constitution specifically forbids the government from picking winners and losers in the marketplace. And I want to highlight some of the constitutional provisions at issue in this lawsuit because they're fantastic. I mean, they're magnificent. North Carolina has a beautiful constitution. Article 1, Section 34 is one of our claims in this case. It's the anti-monopoly clause. It says, perpetuities and monopolies are contrary to the genius of a free state and shall not be allowed. That is not ambiguous language. It's very clear. Article 1, Section 32 says no person or set of persons is entitled to exclusive or separate emoluments or privileges but in consideration of public services. And Article 1, Section 19 says no person shall be in any manner deprived of his life, liberty, or property but by the law of the land, important phrase, nor shall any person be denied equal protection of the laws. The founders in North Carolina, by the phrase law of the land, were hearkening back to the days of Magna Carta. At common law, monopolies were contrary to the genius of a free state as well. They were contrary to the law of the land. So in North Carolina as well. And it's actually interesting if you look to some of the interpretive provisions in the Constitution as well, just to make sure people didn't screw it up, just to make sure judges later down the line didn't try to skirt the actual language of the Constitution. The framers included Article 1, Section 35. A frequent recurrence to fundamental principles is absolutely necessary to preserve the blessings of liberty. So if ever you're curious about what the provision means, go back to the founding and look at what they were trying to accomplish. It was to incorporate the common law prohibition against government-selected monopolies, government selecting winners and losers in the marketplace. Now, you may be wondering, if we've got these provisions in our Constitution and they seem so clear, how is it that we're here? How is it that there's a law like this that explicitly establishes monopolies is on the books? And I want to explain the origins of con laws. So if you go back to the 1960s, state governments started to think, well, we can control healthcare costs by restricting supply. So we're going to do it on a territory by territory basis. We're going to divide up states into geographical regions. And we're going to say that only services that can be proven to be needed in those areas are going to be allowed. And that way we're going to control prices. In 1968, the American Hospital Association recognized the potential economic boon that these laws presented for hospitals, and so they started a lobbying campaign across the country. They had model legislation to get these laws passed. By 1972, 20 states had enacted laws in response to that campaign, including North Carolina in 1971. But North Carolina is different than a lot of states across the country because something amazing happened in 1973. In 73, a hospital was denied a con to build a new state-of-the-art 200-bed facility, and they appealed that decision to the North Carolina Supreme Court. And the Supreme Court struck down North Carolina's con law on exactly the grounds that we filed our lawsuit today. Pop quiz, can anybody guess who filed a brief in support of that law? It was the North Carolina Hospital Association. So the hospital challenged that law under Article 1, Sections 19, 32, and 34. And here's how the Supreme Court framed the case. And it's really interesting. It's just worth reading how the court decided to frame it. The commission claims, this is a quote, and the statute purports to confer on it the authority to forbid the construction with private funds and suitable materials upon private property suitably located of a well-planned hospital, which is to be adequately equipped and staffed with a sufficient number of well-trained personnel in all categories. The sole reason for such prohibition being that in the opinion of the commission, there are now in the area hospitals with bed capacity sufficient to meet the needs of the population. Aston Park, which desires so to engage in the business of caring for sick, injured, and infirm people, contends that this is in excess of the constitutional power of the legislature. We agree. So that's the basis of our lawsuit. That's the exact way that we framed our case, and we're expecting the Supreme Court to uphold its previous decision. So if that decision struck down the previous con law, why are we here talking about it today still? Well, in the late 70s, Congress was grappling, so there are two answers. One is successful lobbying efforts. The other is Congress. And I know we all love to blame Congress, so why not do it here? So Congress was grappling in the late 70s with a problem created by Medicare and Medicaid reimbursements. Effectively, Medicare reimbursed based on actual expenditures. And so the thought was, well, that's subsidizing hospitals and other providers in providing efficient services. They can get money back however they choose to spend their money or provide their services. So prices were inflated. That was the thought. The American Hospital Association, again, saw an opportunity to push con laws at the national level, and so went to Congress with model legislation. In 1974, 1 year after the Aston Park decision, Congress decided to enact the National Health Planning and Resources Development Act, a really great title for a law in a free country, which required states to adopt con laws in order to receive federal health care subsidies. So it didn't take long for the legislature in North Carolina to cave. In 1978, North Carolina reenacted its unconstitutional con regime, specifically in response to the National Health Planning and Resources Development Act. And in the preamble of the law basically claimed the law was necessary to keep prices down. So This would turn out to be an epic fail for a couple of reasons. First, Congress quickly realized its mistake. In '84, Congress shifted to a fee-for-services reimbursement model that eliminated the original rationale for the 1974 Act. Moreover, Congress recognized that cons actually increased costs and reduced access to care. So in '86, Congress scrapped the law. They completely repealed it. But by that point, the damage was done. 49 states had enacted con laws to qualify for federal funding. Well, federal government has since tried multiple times to encourage states to repeal these laws. Vigorous lobbying efforts have managed to keep these laws in the books in 35 states, including in North Carolina, 34 including DC rather. Just to give you a few examples, in 1988, the Federal Trade Commission issued a report concluding that cons harm customers and raise healthcare costs essentially by serving as a barrier to new competition. In 2004, the FTC and the DOJ reaffirmed their previous 1988 study, concluding that, quote, on balance, con programs are not successful in containing healthcare costs and pose serious anti-competitive risks that usually outweigh their purported economic benefits. Market incumbents can too easily use con procedures to forestall competitors from entering an incumbent's market. There's considerable evidence that con programs can actually increase prices by fostering anti-competitive barriers to entry. In 2015, the FTC even sent a letter to the North Carolina House of Representatives in support of HB 200, which would have exempted multiple services, including diagnostic imaging centers, from the con regime. Among the FTC's stated reasons for supporting the bill were that con laws, quote, can prevent the efficient functioning of healthcare markets, quote, can be prone to exploitation by incumbent firms seeking to thwart or delay entry, and, quote, appear to have generally failed to control healthcare costs. Now, that law never passed, no surprise. But don't take the federal government's word for it. Private economists have also condemned con laws and MRI regulations as no exception. In 2015, there was a study in the American Journal of Health Economics that looked at the cross-border effects of con laws, basically comparing states that regulated cons, that had con regulations, to states that didn't for MRI scanners, looking at border counties. So one state has regulation for cons, but the other state doesn't, and you're looking at counties that actually adjoin one another, and concluded that the counties in the state that had no con regulation actually had a greater access to MRI scanners. Now, this reduction in scanners actually matters. In 2016, a study from the Mercatus Center at George Mason found that North Carolina's con law accounts for about a 5.5% increase in out-of-county scans. As Dr. Singh mentioned, patients having to drive for scans is one thing that dissuades them from going to get the scans they need, which can have tragic consequences. The Mercatus Center study also found that approximately 35 fewer scans are performed annually in North Carolina because of these con regulations. So I don't think there's really a serious debate that con laws have failed to achieve their alleged purpose of controlling healthcare costs. But in both basic economic theory and one look at the consequences of these laws on providers like Dr. Singh gives us every reason to think they do just the opposite of that. But they've been remarkably successful at something else, which is their actual purpose. From the start, con laws have been pushed both across the country and in North Carolina by large, well-funded hospitals and established providers hoping to exclude new competitors from the market to protect their bottom line. And there's a reason that hospitals feel compelled to do that. These markets are extremely regulated. It's not easy to be a hospital, I recognize that. But the result is a broken healthcare system that prevents good actors like Dr. Singh from lowering prices and putting patients first. And I'm not an economist, but it seems to me that given the current state of the healthcare system, that's the last thing our government should be doing. And fortunately for us, the North Carolina Constitution agrees. Thank you. So I think now Dr. Singh and I would like to take some questions, and I want to cede the mic to him. If you would direct your questions to him. He's more charismatic than I am.
As I work my way up front, we'll start with this fellow back here.
Sure.
So to play devil's advocate for a moment, obviously this market with healthcare services differs from many others in the sense that there's a prevalence of third-party payment. So the consumer is presented with options and at least contorted or confusing estimates of what it would cost. But at least when you're talking about thousands of dollars of expense, it is at least conceivable that they may not really think about the cost as much because they're assuming, and maybe it's true, that a third party, their insurer, is going to pay the bill. So the argument that I've heard many times is, in that world of third-party payment, if you had more MRIs, then the medical practices or hospitals will order more tests in order to justify having this expensive piece of equipment. So the more MRIs, the more possibly unneeded tests will be ordered, because it's not really coming out of the consumer's pocket, at least not all the time. Many times it might be if they've met their deductible or if there's something else happening, then they at least perceive that the cost is going to be imposed on some third party who's not in the room. And so we have to control the number of, for example, MRI machines or other kinds of expensive devices, because if we don't do that, I mean, yes, there'd be more competition, which in theory should drive prices down, but there might also be more spurious, unnecessary orders of tests in order to justify the existence of this machine at this practice that otherwise wouldn't have enough business to pay the bill.
Let me ask you a question. Who's going to be ordering the unnecessary test? The hospital?
Whoever owns the MRI machine.
I don't agree with that. The hospital, if I want to order MRI, as many I want, or CT scan, I can do today. But all the medical professionals are bound by code, by ethics. We took an oath that we're going to do the right thing to the patient. We, as a medical professional, we don't go out there to do studies, even if you're employed by the hospital. I'm not a hospital employee, but I have several friends and colleagues who work for the hospital. Nobody tells them how many CT scan or MRI you have to order. The hospital may be charging $5,000 for an MRI. If they want to make more money, they can ask those doctor, order some more MRI so we can make some more money. But in my career, I've never heard from anyone. So dropping prices would increase the MRI order. I don't agree with that. If they really want to make more money, they can force those doctors to do those today. But I don't see it happening anywhere. By opening the market, I think it will reduce the prices, and I don't think it will force anyone to do anything which would be unethical or illegal.
I mean, I certainly know that, I mean, I've just had my own experience where I was in a hospital in a different state, and they ordered an MRI of my wife. She had several. They didn't bother to pre-clear it with the insurer. The insurer was not going to pay for another MRI. The hospital did it anyway because they wanted to have their own test, their own information. So it ended up being an out-of-pocket expense for me. At the moment in time, I did not know that. So the point I'm making is, again, this is devil's advocacy here. I'm not just saying. The point that some argue is that whether it is the doctor or a physician practice that might have a machine, or a hospital that is affiliated with a physician practice, or something, that there might be, in a third-party payment world, there might be a perception that if there are more machines, you've got to have enough business to justify having this machine, and on the margin, it might lead you to ask for another test that you wouldn't ask for if you weren't trying to pay that machine off.
Not necessarily. When you end up in an emergency room, I've been a surgeon for a long time. I work in an emergency room. I still take calls. If I have to see a patient in an emergency room, if the patient is from Atlanta visiting over here and got an abdominal pain, and if I need to see that patient, I have no relationship with the hospital. I do not care how much money they make because they don't pay me any salary. But if I'm taking care of a patient who's traveling from out of town, and patient may have a 50 CT scan MRI done, but right at that moment, if I need to see the patient, I can't get those images. I don't have access to those reports. So even the patient says, I have a CT scan in the last week, but ma'am, you're here in the emergency room, you're hurting, you're doubled over, you're vomiting, we need to do something now. It's 12 o'clock, middle of the night, I can't get those records. So if you're saying that we assume that physicians or hospitals are gonna start ordering more tests based on the assumption that if we drop the prices, open the market, I don't agree with that. Those things are done. Your wife in a circumstance went to the emergency room or any physician's office. If you had the disc with you, like when I do CT scan, MR, or any test.
I did have a disc.
Right. Well.
They did it anyway. But I mean, I'm not sure that they shouldn't have.
Right.
I'm just saying this is a confusing situation for many people who don't, of course, deal with these kinds of decisions on a daily basis. This is an argument I've heard from hospitals against reforming CON. So I just wanted to see how y'all would respond to that.
Well, there are several states which have repealed the CON. There is no study published so far in all these years since the federal government took the CON out in all these 14 states. There is no study so far, which I know of, that says that since we took down the CON, the market is open, the prices are down, there is an increase in the imaging studies. Do you know any of those? Because I don't. I'm not aware of any such study or any market analysis like that.
I am shocked to discover that empirical research would undergird and support the idea of free market competition. I can't imagine that that's the case, but I'll get back to you and see if I can.
Great, thank you. Josh, you had to add anything?
No, that's great.
All right, other questions?
Yes, ma'am.
Was there a lawsuit up in Virginia on CON, and how did that case come out, and how is it different than the case you have here in North Carolina?
Yeah, I mean, there was a lawsuit in Virginia. I don't remember all the facts of that case, to be honest with you, but the gist is the plaintiffs in that case, and it was litigated by the Institute for Justice. It was a number of years ago, it was before I got to the Institute, but the plaintiffs in that case lost on basically a motion to dismiss, and this case is different than that case. I mean, we're not making federal constitutional claims, and frankly, North Carolina's Constitution protects individual rights and healthcare freedom a lot more strongly than the federal Constitution does, and so I'm not expecting to run into the same pitfalls here, to be honest with you. I mean, there's binding precedent from the North Carolina Supreme Court striking down a law on exactly the grounds, under exactly the provisions we're challenging the law, and if that's not going to happen here, the Supreme Court's going to have to reverse its previous decision.
Tony?
Do you have any allies in the General Assembly? Because I'm curious that a General Assembly that seems to react to demand doesn't seem to use that in this case. In other words, the suppliers are dictating that nothing changes, but like in the case of charter schools, we've increased the number of charter schools based on the demands of the public. It looks like there's no allies in the General Assembly for the demands of what's needed.
I'm not sure that's quite right. Every year or two is a law proposed that either in the House or the Senate to amend this law, like HB 200, which I mentioned earlier, or completely repeal the law. So there are a number of legislators in North Carolina who are on the side of healthcare freedom here, or at least recognize that if this law isn't going to be scrapped or shouldn't be scrapped, it needs serious revision, right, and serious reform. So there are a lot of legislators who are willing to take that line, but it's a tough proposition to get somebody to stick their neck out and do something very radical like scrap a law that's been on the books since 1978. So sometimes you need courts to make the change that has to happen. Yes, sir.
Are y'all the first to challenge this the new con law in court?
Nope. In 2011, in the Hope case, this law was actually challenged under a number of different constitutional provisions. It's not the same case, to be honest with you. So that's why I'm not too troubled by the Hope decision. We're making different constitutional arguments here. And also it's worth noting that while the preamble to the 78 law includes these legislative findings of fact, which the court in the Hope case, it was the Court of Appeals, by the way, in 2011, which the court found so persuasive. I mean, MRIs began being regulated in North Carolina under the con law in 1993, so findings of fact made in 78, I'm not sure how those really apply to a 1993 amendment. So I'm not too concerned about the Hope decision. The Court of Appeals may rule against us if we go that high, but at the end of the day, this is a decision for the North Carolina Supreme Court to make, and they're either going to affirm their precedent or they're not.
Which court are y'all in now?
We're just at the trial level right now. Yeah, the defendants have until October 4th to respond, either with a motion to dismiss or with an answer to the complaint. So we'll hear back shortly.
Who are the defendants, and the CONs, I've read about them before, it covers other things other than MRIs, is that?
Yep.
Is that correct? Like, what other, and if you win, is that gonna strike across the board, or like, what would be a couple of other examples of who needs a con to do what?
Yeah, so so two questions, right? Who the defendants are, and then who the law covers, and what the impact of the lawsuit would be. So the defendants are DHHS, Department of Health and Human Services, Mandy Cohen in her official capacity, who's the director, or the secretary rather, Governor Cooper in his official capacity, and then we've got two legislative defendants who just sort of have to be added to the lawsuit because we're doing a facial challenge to the constitutionality of a law. So Phil Berger and Tim Moore are technically defendants in the case, but I've got no gripe with them. But so as far as the impact of the lawsuit, if we won, we would get basically an order from a court saying the MRI-CON requirement is unconstitutional and an injunction preventing the enforcement of the law against Dr. Singh. So it's only, this lawsuit is only about the MRI-CON requirement. If we win, that requirement gets invalidated, but I find it hard to think that that's not going to put serious pressure on the legislature to further reform the law after that point.
When it was found unconstitutional and the government basically blackmailed the states into putting it back in place because of reimbursement.
Yeah, it's a strong word, but.
Well, yeah, because it all usually comes down to money, one way or another.
Yeah.
How were they able to justify it when it had already been struck down once in North Carolina being unconstitutional? How was the legislature able to?
They cited the same reimbursement-related concern as the federal government did. So if you look at the preamble to the '78 law, which is still on the books, there's I don't know the exact language, but there's a reference to the fact that reimbursements cause problems in the healthcare market and the prices are going up because of that. And so it's very clear that the legislature was responding to the same issues that were highlighted by the federal government. And I mean, honestly, I think what was really going on is North Carolina state legislators just wanted to qualify for federal funding, and I can't really blame them. It's just that's how politics works. But the harm is to people like Dr. Singh and the people who want to use his services, honestly.
So when it was reinstated legislatively. It wasn't like a bureaucratic decision by DHS.
No. I mean, no. There's a new law enacted in 1978. Yeah.
Thank you.
Yep. You got it.
Follow up on that question, what else is subject to the con law besides the MRI?
Oh, I'm sorry. Yeah, so there's a number. I can't give you the whole list, but there's it's hospital beds, ambulatory surgery centers, nursing homes, in-home care services, and then there's just a whole list of equipment, and you can go look at it. It's something like 25 different healthcare services, but it's a pretty big list. So.
Just to give an idea about getting an MRI and leasing an MRI to provide the services, my goal is to keep the prices as low as possible where you can afford them, and I can afford it and I can provide it to the community. If I have to purchase an MRI and pay my monthly installment, and if I have to lease an MRI, my installment for purchasing an MRI, which I can use it every single day, would be less than half, which I would pay for just having an MRI 2 days a week. So you can imagine how substantial the difference in leasing an MRI. Affording a leased MRI is very expensive. So there's two things you can do. You can jack up the prices or don't offer the services. If you have to have it every single day. And that defeats the whole purpose of having an MRI where you can provide the community services at an affordable price. If you have to charge the same price at the hospital, there is no reason for me to have MRI. So that's where the con law comes into effect, that's defeating the purpose for us to provide the affordable care.
Yeah, I just want to add one thing to that. I mean, part of the interesting part about being involved in this case is that, I'm a free market guy, and I tend to think the competition is pretty much good for everybody, as long as that people aren't committing fraud or any harm to other people. I think competition is a good thing. I think it's really tragic that because this market is so regulated, because we're at a point where people can't ask basic questions and get basic answers anymore from doctors or insurance companies or legislators or anyone. It's a morass. It's a quagmire. It's impossible to figure out for the layperson. There's a lot of skepticism towards hospitals, towards doctors, towards insurance companies, towards legislators, towards pretty much everybody, that no one's out for the patient's best interests. And, I understand that concern, and I think it's understandable that from my mom's perspective, right, she feels like everyone's out to screw her. And I get that. I'm not really here to point fingers at anybody and say that somebody is the one cause of this, but I do want to suggest that a law that takes somebody like Dr. Singh, who, at least in this case, if you're just sort of talking about his story, is doing what a doctor should be doing, which is looking out for his patient's best interests and trying to do the best he can to help them, even at substantial personal cost, right? He's not out there to drive a Lamborghini, as he often says. He's out there to make just enough to keep this center running, to provide low-cost scans for his patients. That's an admirable goal, and whatever you think of the different parties in this dispute and the government's interests here, that is the last thing government should be doing, is preventing someone like Dr. Singh from fulfilling his sort of Hippocratic oath and his personal mission of helping his patients. I mean, it seems to me that that's just the opposite of what government should be doing.
Here.
Roy, health insurance companies
To be honest with you, I haven't gotten any feedback from them. If you're here from a health insurance company, come talk to me. I'm happy to listen to your perspective on the issue, but frankly, I haven't heard one way or the other.
Actually, in my personal experience, in the beginning, we started with cash only, but we got so many phone calls from the patient who had insurance like me, and they could not afford it. So we got so many phone calls like, would you take my insurance, please? I need an MRI, and I've been waiting for 6 months. So finally, we worked with all the insurance company. Now, I wanted to provide the transparency. So our prices are online on the website. So before you walk in the door, you know how much it's going to cost you, and there is no other bill. That's how healthcare should be. Like, if you go to Target or Walmart, it doesn't matter if you're wearing Gucci shoes or flip-flops. It's a bag of chips is $2 for everybody. It doesn't make any difference. Then why it happens for the healthcare? Like you're going to the shop and you want to try a dress on, how much it costs? I don't know. Just try it on, and once you try the dress on, you have to buy it because you put it on yourself, and you're going to pay $1,000. That's how the healthcare. No, seriously, that's how the healthcare works. Like, how much it's going to cost? We don't know. Just have it done. And when you have it done, why it's $7,000? Well, you didn't tell me before. Well, we don't have to. So first thing is the transparency. So we made it completely transparent. It's on the website. You want to come, X-ray is going to cost you $70. Ultrasound is $199. That includes everything. So that takes all the confusion, all the mystery out of the picture, those things. And then you work with the patient. When I got all these phone calls from the patient, we talked to insurance companies. And the two insurance companies, one of the biggest one in North Carolina, they said, it's very interesting what you're trying to do, but we don't have any category for you to fit in because we work with the hospitals, so we don't know how to give you the contract. And I said, I don't want too much money. Just give me what I'm charging cash, the lowest prices in the state. And they said, let us think about it. They came back to me, their vice president, and says, we're going to create a special category for you, just for you, so we can give you a contract. And that was a big deal. They said, we have never done this in North Carolina, ever, to anyone. There's somebody like you have come up and provide affordable services, but we don't have any category. And every single insurance company was very receptive when we reached out to them. And we actually are on preferred list, or all the insurance company, except a couple of companies, they don't want to work with us. But every single company has said, you are our preferred imaging provider. If somebody wants imaging done in certain malls, they go to you because you are the lowest cost. So their point of view on the con law, that's not clear. But they are all up for providing affordable imaging because it saves them money. I don't know if they can transfer the money, give it back to the community. I don't know about that. But they were very happy with what we were trying to do.
In your experience, what leads to that lack of price transparency, and what could we do to maybe open up the transparency as far as what, the main reason you opened the imaging center in the first place?
I think, like I have done, like we go for grocery shopping, every hospital should have a price list. If you want a hernia done, this is how much it's going to cost you. It's not like you got a one bill and then second bill and a third bill and a fourth bill. One of my staff member had a breast biopsy done in the hospital. The bill was $7,000. We can do the same thing for $500. Why? So these are the things. And if we have the transparency, if everybody knows that the one hospital knows the other hospital how much they are charging, and the patient knows too. This is the mystery effect which the con law and everything has kind of promoted, that we are hiding all these numbers. We're not telling them. And this is my personal experience with my wife's surgery. There were bills and the bills and the bills and bills. And I'm being a surgeon and doing my own billing and coding in my own office, independent doctor. I had a hard time understanding those bills. I could not figure this out. I've been doing this for a long time. So for an ordinary person who does not know anything about the medicine, I don't think it's possible at all. So transparency comes where you put down on it. Then it should be mandatory for every hospital, every healthcare, every doctor's office. You're trying to do a hernia repair, this much is going to cost. You want an injection in your knee, this much is going to cost. So consumer can do doctor shop. They can go wherever the lowest prices. And we don't do it for there's a 3 pizza shops and another one wants to open. You can't open a pizza shop because the business go down on other one. You want to open a restaurant, you can open a restaurant. Should be open and free for the healthcare too.
Any other questions? Yeah.
Yes, sir.
I don't want to take everybody else's questions that they have, but
an argument I've heard, sort of a fallback argument. And I've actually, I think that's something I wrote, I quoted somebody saying it. They say, yes, indeed, certificate of need laws raise prices and increase our profits. But we need that additional profit margin to subsidize our charity cases, right? So they acknowledge that it raises prices, they acknowledge that it increases, it gives them monopoly profits, but they're saying, essentially, it's a tax that we are using to pay for charity cases. Have you heard that argument, and how have you responded to it?
Sure, I mean, it's a pretty common one, right, that hospitals are cross-subsidizing, right? Look, I think that, again, I feel sympathy for hospitals because they're hamstrung by so many regulations that require them to spend massive amounts of money on things that ordinarily in a free market, you probably wouldn't spend money on if you're going to spend your money efficiently. Now, that said, I don't think the solution to hamstring hospitals is then to hamstring everybody else.
Right.
I mean, we're not better off if we handcuff every single doctor in the state. That's just not how economics works, So, I don't think preventing Dr. Singh from helping people he actually knows is justifiable under our state's constitution, and that's where we're coming from with this.
I have one point to add in there. I was in a meeting like this last year where one of the hospital administrators, actually happened to be retired administrators, was sitting in the meeting. And the question came up like this, and when I started talking, the hospital administrator said, well, I disagree with you. Well, in this year, like 2014 or so, we saw these many charity people, and we wrote off $80 million, okay? And you're a nonprofit, right? How much money did you make that year? Like $400 million? So you are not paying taxes on that money which you're generating. Your CEO makes $5 or $6 million, and you got dozens and dozens of administrators who makes like $500,000 or more money in there. And you're saying you're saving tax money. If you started paying taxes on that money, you don't have to save that $80 million. We can provide the services to everyone. You can provide the insurance to everyone and healthcare to everyone. So the nonprofit, kind of like a scam for me. Like a hospital make $500 million or $1 billion, pay millions of dollars because they provide a small amount of charity care. And those charity care, if you look at those numbers, they're inflated prices. The ultrasound or CT scan should be done for $100, $200, $500. They mark up those prices 10 times, and there's an article published on how much hospital can mark. If you're saying, I did a charity care on this patient, I did an MRI on this patient, and I wrote off $10,000, that's wrong right there. That should have been $1,000, $500. So when they say they wrote off $40 million or $50 million, that actually comes down way less than that.
Would it make sense just to make it an actual tax? Just in the name, really, in the name of transparency, instead of making the tax the monopoly profit, which is a tax, just put it in the state budget and let the people vote on whether they want to pay that tax or not.
Roy, I can call you Roy now, right? As a libertarian, you won't get me coming out in favor of a tax. But if your question is, what's the best of two evils? Sure. What's the best of two evils? Sure. I mean, if we're talking about just because one thing that does, right, is it makes it objective for providers. So one of the things that's so troubling about the con law is that people like Dr. Singh can't even know whether it's worth. Like, say there was a need determination that actually went into effect in 2019. And Dr. Singh had the opportunity to apply for a con. Well, is it worth it to apply? I talked to a provider who applied for a con. I'm not going to tell you who or where, but in the state of North Carolina, 5 times, was rejected every single time after hospitals filed papers intervening and trying to get their application either rejected or contested when the con was granted. So they spent hundreds of thousands of dollars over the course of almost 10 years trying to get an MRI scanner, and eventually they just said no. I'm done with this. I'm done trying after wasting that much money. Could patients have used that money? Yes. Was that money good for the healthcare market and prices? No. So it's not, Dr. Singh, if he's in a position where he actually could apply for a con, he has no incentive to actually do it. I mean, is he going to blow hundreds of thousands of dollars and then risk, having to close the center and not providing the scans he's already providing to his patients just for the chance to maybe one day purchase an MRI scanner? It's not worth it.
On that note, let's thank our speakers.